Okay, I think we are live. So,
There you
good
go.
evening, everyone, and welcome to a conversation with myself. I'm Olivia Cordia, trustee at the Public Health Collaboration Charity. And tonight we have a special guest, Dr. Anthony Chaffee, who is one of our speakers at the conference this year, and he'll be joining us in just a few weeks, not very long now at all.
Yeah.
So we're going to have a quick catch up tonight and look ahead to the conference and see what Dr. Chaffee's most looking forward to. And very glad to have you all here. So thanks for joining. I'm just going to start off by telling anyone watching a little bit about the Public Health Collaboration, which you may not be familiar with. We are a charity that is based in the UK, and we exist to try and inspire and educate the public and healthcare practitioners about the importance of metabolic health and how it's so instrumental in us all having good health in our lives. Our vision is for a society that enjoys good metabolic health, and a lot of what we do is about not just educating people but also running programs to help people take action with their with achieving metabolic health. And those programs include helping people reverse their type 2 diabetes, reverse their food addiction, and we also help educate children in schools to actually understand what real food is all about and how to distinguish between the best foods that they should be nourishing their bodies with and not. So we have lots of different programs in the UK here that are putting all of that into action. Many of those programs are accessible to people all over the world, especially the food addiction one. So we are fully a charity. If anyone thinks that that is a worthwhile cause, we really do appreciate people supporting us. We are not funded in any way by industry, therefore we rely on people funding us and supporting us at the grassroots level. So that's what we are all about. And the biggest event that we have on our calendar every year is our annual conference, which is in May, and that's what is coming up. And for the last 2 years, it has been frequented by Dr. Chaffee, and it's going to be, although it was remotely a couple of years ago, it's going to be great to welcome him back to the conference this year. The theme of the conference is prevention or prescription, which feels like a very appropriate title with everything that's going on in the wider space of health in terms of how we try and really make a paradigm shift in the way that we look at health. So thanks everyone for supporting us and for coming along tonight to find out a little bit more about what's in the conference. And I'm just going to start by saying to Dr. Chaffee, if you wouldn't mind just introducing yourself quickly to anyone who isn't aware of yourself or your work, and that would be great to kick us off, and then I'll ask you a few questions.
Sure. Yeah. Well, I'm Dr. Anthony Chaffee. I currently practice in Australia, but I'm from America originally. I lived in Europe and the UK, Ireland, etc. And I've just been researching diet, nutrition, how that affects health and chronic disease for many, many years now, and have been applying that into my patient population and base, and have changed my practice to mostly focus on that because just touching on what you said about to prevent or prescription, I've found that taking a preventative medicine approach, the same techniques that can prevent diseases from starting in the future can also help reverse those issues and diseases now. And so that's actually, the prevention is the best prescription. And so you start with that. You start with the diet and lifestyle changes, and a lot of these chronic diseases do go away on their own, and you can use some medications to bridge that gap. But a lot of the time, people are coming off medication and improving their health, and just getting a lot better without the need for the whole sick care system, which is really rewarding. So that's what I do, and podcast, YouTube channel, obviously, as some people are on watching from there.
Yep, thank you very much. That's a great summary. And this year, Dr. Chaffee, we are going to be asking you to participate in 2 of our themes. We have about 4 or 5 themes going at the moment. One is on weight loss drugs, which is something a lot of people are hearing about these days and may not know whether or not that's a good thing or not to look into. And so we've got some great people talking about that theme. And we also then are talking about themes of cancer and the future of health. And so you are involved in the cancer segment that we are going to cover, which is also going to involve Professor Thomas Seyfried, who I spoke to just the other night, Dr. Isabella Cooper, and Dr. Matthew Phillips. And they are all going to be part of a panel and individually talking about their work on cancer, which spans different aspects of research and clinical work. So I wondered if you could maybe talk a little bit about your view on the metabolic theory of cancer as you're going to be moderating that panel, and what you might want to ask those very knowledgeable individuals, and what you think the main messages are that we need to kind of bring to light about the theory of metabolic cancer.
Well, I would certainly align with all the panelists, and certainly Professor Seyfried in the metabolic mitochondrial model of cancer. I mean, the evidence is quite overwhelming that this is not simply a genetic issue, seeing as that there are some cancers that don't have any genetic changes whatsoever, and other cancers that have the different cancer cells in the tumor, they may or may not have genetic changes at all, and yet they all behave as cancer. But one consistent feature is that they all have damaged mitochondria, and the mitochondria actually control cell division and replication. So if this cell is damaged and shouldn't divide, the mitochondria are what physically stop it. And if the mitochondria aren't there, it can't be stopped. And it's like a runaway train. And that's what cancer is. It's unregulated cell growth. And so we see this. There's a number of experiments that have shown this, going back 80 years with Dr. Otto Warburg, who's a Nobel Prize winner in his work in medicine and physiology. And so I definitely align with that. I think it's a very important message to get out, especially to clinicians, because if you have the wrong diagnosis, you're certainly going to have the wrong treatment. And so any sort of success you have with treatment is going to be more luck than anything else. And that's sort of what we've been seeing. We haven't really made too groundbreaking advancements in cancer. There have been some treatments, immunotherapy, things like that for things like melanomas has been, very, very beneficial. But there's a lot of other ones that, it's very hit and miss. And so cancer is still a devastating disease. And even with our knowledge of medicine and advancements, we are not really winning the war on cancer. And cancer rates and prevalence are actually getting worse, they're actually getting a lot worse. When I was a kid, cancer rates were still relatively rare. In my mom and dad's generation, in the 40s and 50s, cancer was still the C word. It was just, you just didn't talk about it because you want to bring this curse in on your house. It was so rare. It was just, oh, this C word. You wouldn't say they had the C word. And now, 1 in 2 people at some point in their life will get cancer. 1 in 2. That's insane. So clearly, there's something else going on here. Clearly, it's not just genetic. Um, there's some sort of environmental factor, and I mean, even if it were genetic, it could be environmental factors that are damaging our DNA. Something is happening in our environment, and it's very, very damaging. So I would definitely be in that camp. I've seen a lot of Dr. Seyfried's work and his research. It's very compelling. I was involved in one of his publications as well, and yeah, so I saw that process go through, and it's extremely interesting. And I've seen this certainly help people. And it's not a replacement for standard of care. You don't have to replace standard of care. Many people are using this as an adjunct, and it can help benefit that even further. So, yeah. So the different things on what to ask. I mean, it is really just to sort of flesh out their views on this. You're going to have specific individual talks, and so I'm going to have questions about those talks. And also, I think it's important to have sort of a practical day-to-day approach to this. People will say, okay, well, that theory is all well and good, but what does that mean? What do I do? And that was actually the basis of the most recent paper that Professor Seyfried and his team published, and I was a co-author on. And so talking about that was what are the day-to-day sort of thing. And then what about some alternative sort of off-label prescriptions being repurposed for cancer, things like ivermectin, fenbendazole. They have different sort of properties that can potentially be beneficial. Some people are thinking because these things are antiparasitics that cancer must be a parasite. Unfortunately, we've never seen, or I've never seen any parasites in these cancers and tumors. But there are very similar properties in the physiology between cancer cells and some of these parasites. And then so there's the cross reactivity, like fenbendazole, for instance, blocks glutamine, and cancer cells can run on glutamine and glucose. So those sorts of things, asking those and getting some practical tips for doctors and patients.
Thanks for outlining that. And just out of interest, who do you think needs the most education at this point? Is it the public or is it the healthcare practitioners? Because we do get a lot of
Mm,
people coming to us and asking, I really want to explore this, but my practitioner doesn't know anything about it. I want to do it
mm,
alongside what they're recommending to me, but
mm.
they're just not aware of it. So people feel
Yeah.
really lost, and it sounds like the paper you just referred to is starting to answer that
Mm.
question a little bit. But yeah, it'd be lovely to know your views on that. Like, do you think we should just really focus on the healthcare practitioners right now until we have a little bit more of a kind of groundswell of education?
I mean, I think it's really important to get clinicians involved with this because they're the ones that are going to be dispensing these treatment plans. And so, if you have the oncologists really behind this and understanding this, as more and more are, I was very surprised and pleasantly surprised when I gave a lecture on this to my neurosurgical department in Perth, and I invited the oncology teams to come and be a part of it as well. I didn't get a response from anybody except one radiation oncologist who just replied back. It's like, "Oh yeah, absolutely, of course. I mean, you're limiting the glucose supply to the cancer. Of course, that's going to work. Of course, that'd be helpful. Yeah, would love to attend." So it was like, "Well, all right." So there's already people that are aware of this. Nobody else was interested. So it just yeah. So I think it's really important to get the clinicians involved because if you don't have them involved, I mean they may just be impartial to it and just say, oh no, that's crazy, you don't do that or something like that, and they might talk them out of it. It is something that you can do on your own. Just don't eat carbs. It really boils down to that. I mean, just don't eat carbohydrates, and you're going to limit the amount of available carbohydrates to the cancer cells because cancers require 400 times the amount of glucose as normal cells. You'll make glucose, but by gluconeogenesis, there's a paper that came out this year that showed that regardless of what you eat, carbs or no carbs or fasting or whatever, gluconeogenesis is steady. You're going to make the same amount of glucose regardless of what you eat. And so, if you're eating carbs on top of that, you're just adding to the pot. And so, um, you can do that on your own. You don't need physician supervision. I mean, a lot of people are doing ketogenic diets, carnivore diets without any doctor sort of telling them how to do it because most doctors don't know how to do it. So, there are resources online that people are finding and they're just applying it to themselves. Fasting, these sorts of things, being in ketosis and fasting, going into chemo and radiation. There are multiple studies showing that this protects your normal cells, your healthy cells against the chemo and radiation, and makes the chemo more effective for the cancers as well. So anybody can use it. I think it's really important to get it out as a groundswell as well, because when patients are saying, "No, I'm going to do this," and you have more and more people that are doing this, and they're having better success and results, then any conscious doctor and oncologist is going to see that and go like, that's interesting. All these ketogenic patients, these are the ones that are all doing the best. And if they're paying attention, they might see that and they say, okay, well, maybe I should look into this. And they'll see there's an abundance of research on this. But ultimately, we need to get it to the clinicians. We need to have this as a top down uh, sort of prescription that people understand, especially oncologists, that this is something that can benefit their cancer patients and improve chemo and radiation. And then for people that just really aren't tolerating chemo and radiation, they're getting horrible side effects. And this happens. A lot of people die from the chemotherapy as opposed to the cancer.
Mm.
This is a viable option, that you can at least do this as well. And there are people, I believe, previous speaker, Andrew Scarborough, he's a 12-year survivor now of glioblastoma brain cancer, which is the most aggressive primary brain cancer. It's extremely resistant to chemo and radiation. The best treatment is surgery. He wasn't able to get a full complete resection because of the location of his tumor. And so, because his tumor was even less sensitive to chemo and radiation, he ended up just opting for ketogenic metabolic therapy, doing largely a carnivore diet, very strict. And he's still here 12 years down the road. average life expectancy for someone who forgoes standard of care and cannot get a complete resection is 3 months. And he actually had a more aggressive form, so
Yeah.
it's sometimes less than that. He had a partial resection, so that will do something, but you really need more than a 95% resection to significantly improve longevity. But it's not curative. I mean, you can with GBM. I mean, they're really nasty. It's not necessarily like, oh, here's this one tumor and it's there. You can remove that. You know, if you have a melanoma, you take out part of your skin. You have a big wide resection area. You're trying to get all the cells away, and that decreases the likelihood that it's going to spread. You can't really do that as well in the brain because it's the brain, and you can really hurt somebody or cripple them, paralyze them, depending on where it is. But in some parts of the brain, like the frontal lobe, you can actually take out the whole lobe. And so sometimes you'll have this little tumor in there, and you'll actually take out the whole lobe. So you have huge margins around it. Just shows right back up, you
Mm.
know. And in fact, they went even more aggressive in some cases where they took out an entire hemisphere. So you had this GBM on the left side. They took out the entire left hemisphere, shows up on the right.
Yeah.
Okay, so that's a disease process. You know, there's something more going on there, and yet, without even a full resection, Andrew's still around. And from speaking to him, his more recent MRIs don't show any sign of disease. It's actually recessed, and that's actually what there are published cases and literature on that as well. That
Mm.
these can actually shrink down and go away with these dietary interventions. So it's it can anybody can do it at any time, so you don't have to have your doctor on board to do this, or even knowing about it. But I think that and then having, like Dr. David Unwin, who's going to be there, he was turned to this because he had a patient that was so successful, and it really admonished him that he wasn't aware of this because it was so successful. And so he took that seriously and then looked into it and wow, actually there's something here. And then he started using that very successfully, using ketogenic or even therapeutic carbohydrate restriction, not even going full ketogenic, but just reducing the carbs has a lot of benefit for just general health. And so that's really important too, getting this out to people because people just need to hear it. They need to understand it. They need to know it. And even if no doctor ever, pushes this, people can do this on their own. It's just you don't eat carbs, right? And you don't need carbs. But it will make the most effect when you get the clinicians doing it, because clinicians are going to affect and influence hundreds, if not thousands, of their patients. And that's going to spread locally from there. Each person can individually influence people in their lives, but a doctor can influence hundreds and thousands of people who then go and influence individuals in their lives
Yeah.
and other doctors. Yeah. And then you get more research, you get more publications, and it just grows from there.
Yeah. And we've always said it's definitely both. You need to attack both, and there'll be a
Mhm.
cyclical evolution. And as you said, education comes from patients to doctors, like Dr. Unwin always tells about his story.
Mhm.
So it definitely is both. But I think with cancer, it does feel like more and more people are struggling to really
Mhm.
make any headway with their clinicians because clinicians just don't know enough about this. So it really feels like that is a real blocker, more so than many of the other metabolic illnesses that we need to break down. So really hoping that we'll be able to really have a full discussion about all of that with your leadership on that panel, and that we'll be able to start to make it through to many oncologists and other practitioners in the cancer space. So if anyone is interested in hearing more about that discussion, then please do come along to our conference. I have already posted the link a few times, and I think others have too. It's going to be at the end of May. You don't have to come along in person. You can actually live stream if you're not in the UK. But obviously, if you are in the UK, it is great to come along because there's a great camaraderie, a great atmosphere. People like Andrew Scarborough that you mentioned will be there, as well as many others that are supporting this movement. So if you can come along, then please do and support our grassroots movement. And the other question I was going to ask you, Anthony, is moving on to your main talk, which is going to be about the real healthcare crisis, and then involvement in a panel around the future of healthcare and what it's going to take for us to turn the ship around. Do you have any kind of snippets that you'd like to share with people about what you're going to cover in your talk there?
Yeah, so I mean, I'm sort of addressing what the real healthcare problem is. The real healthcare problem is not, what system we use and all we need, how do we fund it, and all that stuff is important, but it really doesn't get to the crux of the issue, which is that non-communicable chronic diseases, which are horrifically expensive to treat, they're on the rise and they're massively increasing. They're getting higher and higher and higher and higher, getting more and more prevalent. Like I said, cancer, which is not cheap to treat, 1 in 2 people will get cancer at some point in their life. That's unheard of. 100 years ago, there's a professor Wilhelm Fonson from Harvard who wrote a book called "Is Cancer a Disease of Civilization?" Because the Inuit and other native populations had essentially a rate of zero cancer. And so, and even then in the Western world, it was still extremely low. And oh, well, people just didn't live as long. That's not true. Average life expectancy from birth in 1850 was 38, but in the early 1900s, it was in the 60s and 70s. But that's from birth. When you made it to 10 years old, if you made it through the gauntlet of infancy and childhood in that era of with limited access to healthcare and or good healthcare and no antibiotics, etc. If you got to 10 years old, on average, you made it to 60 years old, right? And if you made it to 30, you'd be in 70 or something like that. So you making it up. The older you get, the longer you would live because infant mortality was very, very high. So more and more people are getting cancer. Younger and younger people are getting cancer. Right. So it's not like this is just affecting people in their 70s and just more people are making it to 70. That's not what's happening here. More people are getting affected by this in their 20s and 30s. There are more children and teenagers getting cancer. And so this is a real problem. And so it's just pointing this out. It's pointing out the huge financial burden that is placed on the public. But because it's huge financial burden, that means someone is making that and collecting that. So there are people profiting off of this in the realm of trillions of dollars, tens of trillions of dollars. And so that's a real healthcare crisis. It doesn't matter what system you have. And you can read Thomas Sowell's books and applied economics. He has a whole chapter on healthcare and medical care and things like that, and the different systems. And you can see for yourself which one you think is best. I certainly have my opinions. It doesn't matter. Any any system on earth, any system in heaven will absolutely collapse under the burden of these chronic disease. That they're just going higher and higher and higher. Real quick, sort of uh, piece to that. The Harvard University School of Public Health looked at just 5 chronic diseases, just 5, and so it would be cardiovascular disease, diabetes, type 1 and 2, mental health disorders, cancer, and what was the other one? Cancer.
Alzheimer's.
Christ. Say again? No, it
Alzheimer's.
wasn't Alzheimer's. No, no, it wasn't like dementia or anything like that. So it was, yeah, cancer, diabetes, mental health. Oh yeah, COPD and heart disease. Yeah, so COPD was the 5th one,
Oh yeah.
and so like emphysema, right? And so just those 5, so that's not including autoimmunity. Autoimmunity is very expensive to treat. The number 1 and number 2 grossing drugs on planet Earth are both autoimmune drugs. Number 1, I think last year, they grossed like $24 billion for this one drug, and then the next one down was about $6 billion. That was Humira. I don't remember I can't recall the name of the first one, but it's an autoimmune drug. And then number 3 was 4.5 billion with Ozempic, right? So everyone thinks Ozempic is the largest drug. No, it's autoimmune drugs. So to the tune of $30 billion for the top 2 drugs. And so not including those, right? Not including those, not including anything for Alzheimer's, dementia, Parkinson's, anything like that, autism, which is growing in problem as well. Just those 5 that I mentioned, that in 2010, the direct and indirect costs that we spent treating these diseases was around $8 trillion worldwide, trillion with a T. right? And then by 2030, it's expected to be up to $14 trillion a year in direct and indirect costs. Those aren't all the costs. That's just paying for healthcare and things like that.
Mm.
Then they looked at lost opportunity costs. So people on disability, they're sick, they have to retire early, all these sorts of things. So lost opportunity costs, they can't be productive. Sick days, things like that, disability. That cost just the world economy, estimated 43 trillion dollars between 2010 and 2030. Massive amount. Massive amount of money is just gone from the economy that just will never exist, right? Will never be produced in the first place. And then the largest cost was the early deaths, so premature deaths. So someone having a heart attack and dying in their 30s, or having some complication of diabetes and dying at 45 or 50 or something like that. And then you've lost decades of being productive. I mean, it's just strictly economic costs. And obviously, every dollar amount that is in that as a cost is a numerical representation of the suffering and death in someone's life, right? So that's how you have to think about that. And so the early deaths in 2010, the cost per year to the world economy was $22 trillion in lost opportunity from these people dying early that year. And in 2030, it's expected to be up to $43 trillion per year
Yeah.
in lost economic force from people dying early. So this is insane. And no system can handle that. No system is going to handle that. So all systems on Earth, regardless of the system, they're all crumbling. They're all on the verge of collapse. They're being held by toothpaste and dental floss. I mean, it's just like they will collapse.
Yeah.
Stiff breathing is going to knock these things down. And we saw that with the whole COVID stuff. We had all these reports of Italian hospitals, and that the ERs were full and the ICUs were full. And it was like, oh my goodness, that's crazy. Because we think of that from an American standpoint, like, well, that's abnormal. That must be really bad. They're always full. The ERs are always full. Their ICUs are always full. I worked in Ireland and the UK and things like that. I worked in the emergency department at a major university hospital, St. Vincent's Hospital in Dublin. It, it was at 3 times capacity, 3 times capacity. So it was a 32-bed ER. We routinely had 80 people, admitted patients in the emergency room, stacked up like cordwood in the hallway on beds. And sometimes it went up to, there was a few weeks it was at 150 admitted patients on the floor of the ER. So the teams were coming down, giving all the care to these people. So the ER nurses couldn't do their job and be emergency care nurses. They were like ward nurses. They had 20 patients. They were trying to give out medications and all this. It was bedlam. And we had, resus beds that were always used up with ICU patients that couldn't go to the ICU because ICU was always full. This was a decade. Well, yeah, I mean, I was there, a decade before COVID, and it was always like this too. When I worked there, it was a good 5 years before that. Um, it was always like that. And then they started talking about, oh my goodness, the ERs are full and the ICUs are full. They were always full. You're just showing what they had. So, the system was already verging on collapse, and then you spike in, even more patients, and it really crumbled. I mean, they really were hit hard by that, and so they really couldn't cope. They really couldn't cope with that because they were already on the verge of collapse, and that's because this massive burden of chronic disease is such that we just can't keep up with the load
Mhm.
financially or just from a simple bed space position. Then so when you do have something that comes through like of an infective nature, then you're already stretched past capacity, and things are really really a disaster. So that's the sort of stuff that I get into. And if we fix that, if we fix the chronic disease side of things, well, then we'll be in a much better position to argue over which system works better.
Yeah. Yeah, exactly. And I think it'll be interesting to see in that panel what the different viewpoints are, because, as you say, these kind of numbers, 22 trillion, and that's not putting aside all of the quantity and quality of life that's been lost. That's just looking at
Mm,
financial burden.
that
That's
hard dollars.
yeah,
Yeah.
that every every westernized nation and now many other nations are taking as well. And
Mhm.
it's just not possible to support that.
Mhm.
Here in the UK, and I know in many other places, that the conversation has always been, how do we put more money? Which political party is going to put more money into the healthcare system? They're going to be the winners of the next election because they're going to do more to prop up the system. And nobody wants to have the conversation about, how do we take the cost out? And what does that look like? And what is that narrative all about? So I think a critical part of actually changing our direction and changing the paradigm is changing that narrative and getting us away from trying to just pump more funds into something which is just throwing good money after bad, or bad money after good. But either way, then the narrative has to shift, and I think that's starting to happen now across the world. And we really want that to make sure that takes hold in the really, really great discussion that we're going to try and close the conference off with. And it'll be great to have you involved in that as well.
Yeah.
Um,
Well, I was just going to say really quickly is that I mean this is in all these countries best, and especially countries that have socialized healthcare. Because like I mean, if you can reduce costs in the billions to trillions, like I mean, who wouldn't want to do that? I mean, well, what honest person wouldn't want to do that? I mean, there's a lot of waste in these sorts of things, and so there's a lot of people that don't want that to come down because that's their slush fund. But
mm,
I had my best friend growing up. He was a striker rep, and I was a regional manager, and he was saying that he was working for did a contract with the VA, Veterans Affairs Hospital, and so this is America's socialized healthcare system, and 100% universal, one party payer. Just government just runs everything. They own everything. They run everything. They employ everyone. And so they had these ORs, and so that's what he was doing. He's outfitting all these operating rooms, and this is a multi-million-dollar sort of ordeal. And so the head of the hospital um, wanted them to put in a $24 million revamped OR system for all their operating rooms. And so he goes in there and they're sort of like scoping it out and they're saying what they want to do. And he's like noticing like all the equipment is brand new. And he was just like, it looks like you guys have already sort of gotten this done. And it was like, what's going on? Is there something wrong? Like they went to another company, they spent $18 million, and so the head also said, "No, I don't like it. I don't like it. Just gut it all out. Do it again." And he's like, "This is all brand new equipment. Do you want to do something with it? Do you want to sell it? Do you want it?" He said, "I don't care. Just get rid of it." So they dumped it. They dumped $18 million worth of state of the art medical equipment, and because they had not no, they couldn't do anything with it. It's like they can't just take it home, right? So it's like that's the kind of waste that you
mm,
see, and that's why these things get so expensive. So, the but being able to free up billions of dollars, in some cases, like in America, likely trillions of dollars, is would be massive. And so, in these socialized healthcare systems where the government's paying for everything, why wouldn't? And you always in budget crises, and you're always having problems. There's always something wrong. Why wouldn't you want to free up money and make people better and not have to pay these massive expenses for treatment? It beggars belief that they're not all over this.
mm. Yes, I know, and we have been around
Mm.
that conversation many times and not seen it really
Well,
take hold. And that's why we know we have to get the grassroots.
mm,
We have to get
well,
people rising up to say why.
yeah,
Why isn't that a conversation? Why aren't you doing it?
yeah. Well, that's it. Because if people understand that there's this option and it's their money, and they're like, well, hold, why aren't you doing this? Like this is what we want. And then when people understand that, you'll get in a representative, republic, democracy, whatever. Um, representative democracy is a republic, and when you have that sort of system, and you have enough people, enough groundswell saying, "Oh no, this is what we want," then and someone comes up and says, "Okay, hey, there's a lot of people that want this. Like, I'll do it." Then you can go behind them. And so, when you get this groundswell and this grassroots movement up, then you can get the political influence that you need to sort of make sort of systemic changes like that. But at the same time, you don't need to wait for anybody to get healthy. these, this is your option. You don't need a doctor to get you healthy. You don't need medicine to get you healthy. That's something that we really need to change the mindset of, that people think like, oh, I have to go to my doctor and they'll make me healthy. They'll give me a pill. Someone will figure out how to make me healthy regardless of what I do. Oh, diet doesn't matter. Yes, it does. And so, if you get, if you can just, do the right thing and get yourself healthy, you just sidestep this entire system in the first place, and there's no need for it at all.
Yep, absolutely. And I think that a lot of what you were saying there about, we can take control. We absolutely
Mhm.
can. And it's what's so great about it is that really just changing the way that we eat eradicates the risk for multiple diseases at the same time.
Mhm.
Like we always tend to, again, be stuck in this paradigm that different diseases may originate from different organs and they all have different causes. Well, actually, you don't need to get into that complication. Just change your diet and start eating real food, and
Mhm.
you will be able to preclude yourself from getting many of those conditions. So it's actually a lot simpler than we sometimes think. So just moving us on to the agenda of the conference, we have 2 days. So anyone who's just joined or wasn't here for the start, we're having a conference at the end of May in the UK in London. It's the Public Health Collaboration Conference. It's 2 days, and we are covering lots of different pertinent topics on health. We've got David Unwin and Eric Westman both talking about weight loss drugs and whether they're a good idea or not. And we have some great insight also coming from Mark Cucuzella in the US, who has been using them, has an interesting viewpoint to provide as well. So if you know anyone who's interested in those drugs and is thinking about using them for weight loss or anything else, then this is a great conference to come and find out from some real experts and people who've got experience with it. We also have Chris Kenobi, who is the chair now of the seed oils committee for Make America Healthy Again, and he's coming over to talk about seed oils, something again that a lot of people are hearing about, and you'll be able to hear directly from Chris if you come along and join us at our conference. We have Dave Feldman talking about his most recent paper on the lean mass hyperresponder study and the next steps there, which is really an interesting progression of how we can start to break down the real cause of heart disease and look at it from different angles. And we have the cancer panel that I mentioned earlier that, Anthony, you're going to be part of, and lots more. So if anyone is in the UK, please do come along to our conference. If you're not in the UK and would like to support us, then please do live stream in, and you'll get to hear all of those fantastic talks in person. You don't have to watch it live. You can watch it back over a period of a few weeks. So it's still worth coming along and live streaming in if you can. So the link will be somewhere in the chat, or just go to phcuk.org/conference and you'll be able to get tickets there. And so the question I have for you, Anthony, is there anyone in particular you want to hear from and want to hear what they've got to say, or anyone particularly you want to meet this year? Obviously you were here last year, so you've met lots of the guys, but anyone new this year or that you're particularly looking forward to seeing or hearing?
I honestly, I mean, I'm not just saying this, but I'm really excited for the whole lineup. Like everybody there sounds fantastic. I really like Chris Kenobi, even though he's not, carnivore. He's, we rely on so many things. I just think he's just a really nice guy and he's very interesting. So it always be good to see him. Obviously, I'm really looking forward to seeing Professor Thomas Seyfried, because he's just fantastic, and I've spoken to him and corresponded with him through email and certainly had him on my podcast and things like that. But I'm definitely really looking forward to actually meeting him in person and
Yeah.
getting a chance to talk to him one on one. Matt Phillips is fantastic, and he's a good friend of mine, and he's always a very interesting guy to talk to and listen to. He's doing great research over in New Zealand, although he's from Canada, and so it's always great to hear his updates on his research as well. Same with Isabella Cooper; she's fantastic, and again doing fantastic research. And it would be really interesting to see what the updates are on her research. And what are some of the other ones? I mean, everyone's good. Dr. Unwin, I really like David Unwin. He's a really nice guy as well. And
Also got Jen
yeah,
Unwin talking about food addiction and
mhm.
her
Yeah,
work to
she's
get
great
that
too.
recognized as a
Mhm.
diagnosis.
Yeah, well, that's just ridiculous too. I mean, it's so funny. The same people who say that that you know Fruit Loops or what's wrong with Fruit Loops? It's just food. You can't say anything wrong about it with food. Are the same people that said never eat meat because it causes heart disease and cancer. Well, it's just food, isn't it? So I thought you can't say anything, but it's just food. Food's not bad. It's just food. So some foods are bad, some foods are not, but only when it suits them, I guess. And so, of course, there's food addiction. I mean, it's intentionally addictive. They have food scientists that have said on 60 Minutes that what they're trying to do is put compounds in there that elicit a compulsive eating, right? What does that mean? That's an addiction, isn't it? And making it more addictive, make it cause compulsive eating, and so you eat more, you consume more of the product, right? And that's how you sell more product. If someone buys your product, you sell the product. I mean, that's how that works. And so a lot of these things are owned by or were owned by the Philip Morris and the other tobacco companies. They bought all these things, and then they put their tobacco scientists who were spending decades making tobacco more and more addictive, so that more and more people really ranking up the nicotine in them and all these other sorts of things to make it more addictive, so that you smoked more and that you didn't just have a couple of cigarettes a day. My great grandfather was born in 1875. He died in 1975. He's 100 years old at home,
Wow.
and he rolled 3 cigarettes a day every day and had a glass of whiskey. That was it. And he golfed every day and he was fine. But the tobacco he had, it was like this naturally cured tobacco. It wasn't this hyper crazy stuff. So we had 3 cigarettes a day for decades. Almost no one is doing that. If you're smoking 3 cigarettes a day now, in a few months it's going to be 5 or 6, and eventually it's going to be a pack a day, then 2 packs a day, then 3 packs a day, and you're chain smoking, lighting your next cigarette off the last cigarette. That's how they make money. And and they had their minutes for their board meetings, talking that were leaked later on, talking about how they weren't allowed to advertise to kids, so they needed to figure out different ways of doing that. So they made like candy cigarettes and different bubble gum that would be like a bubble gum cigarette you could blow through and like powdered sugar would come out. So I was like, oh, it's smoking, it's cool. I remember those as a kid. I bought them once. They were just a shit candy, so I didn't buy them again. But it was just sort of fun at first, like, "Ooh, people think I'm smoking." Then I'm like, "No one thinks I'm smoking. I'm 7." And, but it's like trying to make that cool, and then they did it with food. They're trying to make it as addictive as possible. They got those tobacco scientists in, as food scientists, and they said on 60 Minutes, people can look this up, 60 Minutes USA, they they says like, well, what we're trying to do is find these chemicals that give this, yes, this is good for you, change it, alter it so it really amplifies that reward expression in taste and chemical response to your brain, and then goes away quickly. So you want the next bite, the next bite, the next bite, the next bite, the next bite. And so just that, and not even to speak about the addictive nature of sugar and the compulsive habits that can be formed from carbohydrates, raising insulin, having reactive hypoglycemia, and now you feel horrible, so you need more, and then blocking leptin, which is satiety hormones, so you never feel satisfied, all these sorts of things. Just that you wanting that taste, you wanting that experience, and it goes up and it goes down, quick in and out, quick in and out, quick in and out. You're going to eat more. You're going to eat more compulsively. Now I heard something that like Bill Gates owns like Kraft and those sorts of things.
Yeah.
Perfect. So and Coca-Cola, what the hell did that happen? So these things are being abused and manipulated, and we're being manipulated. And so anytime you're seeing these people come out and speak out against this, and it's, oh, no, 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 it's just food, blah blah blah, that's being paid for. That's a paid advertisement, whether it says it or not. And so it's it's something that we just have to be aware of. These people make trillions of dollars a year, trillions of dollars a year, just selling us this garbage that makes us sick. And then they make tens of trillions of dollars giving us the medication to perpetuate that sickness, but
Yeah.
never cure it. Because the cure is stopping eating the garbage in the first place, right?
Yeah.
And if you cure a disease, a customer cure or patient cured is a customer lost. That's a flippant saying, but it is 100% true, and that is how they think of it. Goldman Sachs said this in one of their board meetings, and it was leaked to the public. Someone took a picture of it and leaked it, saying, is it a viable business model to cure someone of a disease? And the answer, of course, was no, because once you cure them, you can't treat them anymore. You're done selling them. But if you just treat the symptoms and they have the disease for the rest of their life, well, now you're in the money, because now you can sell them that every single day. It's like a tithe on people's health. So they have to spend a proportion of their money, 10%, 20%, 30% of their income on just staying moderately healthy so that they can continue to exist and just take care of their families and live their lives. So they're just garnishing their wages and just on just living instead of just being allowed to be healthy. And we're being done, it's not to benefit people, it's to benefit themselves. And they know this, and as Callie Means said, he was a whistleblower on this. His sister was just named, his sister Casey Means was just named Surgeon General, which is fantastic. But she's coming on a huge fire because they're trying. Oh no, this is terrible and blah blah blah. These are all the paid talking heads that are trying to save their ass, for this trillions of dollars. But Callie, who was an insider with Coca Cola and Pfizer, or some other food and drug companies, he said that they know that these foods are making people sick, metabolically sick, and they're profiting from the sickness, and that, by selling them drugs as well. He said, I know that they know this because I was in the board meetings with them when they said it. Right. And so, they know what's going on, and they're intentionally trying to make us sick and profit off of us so they can just garnish our wages and just be like, the feudal system. I mean, this is every time, I sort of think about this, it's more true to me that they're trying to get back to a feudal system of oligarchs and land barons where they own everything, they own the land, they own the people, and they just milk the people. The people have become the cattle. And then we just have to work and toil, and they just collect, a significant portion of that for the rest of our lives. And we're never going to be owning land. We're only renting. We're renting it from them. We can't even, buying our food from them. They'll, like the old coal miners. They lived in these coal miner towns, and the company's store, what the prices were set just higher than everybody could afford, and so they got paid on how many tons of coal that they dug a day, and the prices were just always out. So they always had to take loans. They had to take loans and had to take loans, and when their kids were, old enough, as in 7 or 8, they came into the coal mines with them to start working off their dad's debt and things like that. There's a famous song, where it says shovel 16 tons, and what do you get? Another day older and deeper in debt, and I sold my soul to the company store. That's what they're trying to do again. They're trying to get
Mm.
us back there. They own the food supply. When you control the food supply, you control a population, and you control their health care. If everyone's sick all the time, you really got them by the balls. And so, they're trying to do this. They're trying to buy up all the land and make it impossible for anybody to get into a home. If you don't already own a home, it's very unlikely you're going to be able to afford a home unless you go really far outside, from the cities. And and it's going to get worse. It's going to get worse and worse. And then you're paying tithes on all this medical care and all this sort of stuff. And Goldman Sachs, they actually admonished a company called Gilead when they came up with an actual cure for hepatitis C, which I was really impressed with. I heard about that my intern year in 2013, and I was like, "Wow, that's amazing." And apparently Goldman Sachs sent them like an angry letter saying this was a big mistake. You never cure anything. You want to treat the symptoms so that they can live with the disease. You never cure the disease because now your customer base is gone, right? And then you have to go on and spend $1 billion in R&D for something else,
Yeah.
and instead of actually, screw this trying to help people. We need to, we need to make money here.
Yeah.
And so it's truly sick, honestly.
Yeah. But I think there's sea change kind of happening at the moment, and especially
Mhm.
with Casey Means, as you said, now being appointed as a Surgeon General. That's a really big
Mhm.
change in the
Yeah.
narrative. And the narrative is what we're really suffering from, I think, most of all, because what you were saying earlier about food addiction. Obviously, it's some of these foods are very highly addictive, but yet the narrative is that you should be able to eat all types of foods. And if you don't eat all types of foods, then you have some kind of food disorder. So, that again doesn't make any sense. And we've actually looked back because we've got a food addiction program in the public health collaboration, and we help people reverse it. And we've looked back at the literature to see where is it that people have restricted certain foods and develop food disorders. Is there any evidence for that in the literature? And there just isn't. And so that is something that has come up as a bit of a myth. It's probably been propagated by companies that want it to be true, and people now talk about it, and nutritionists talk about it because that's what they're taught, which is that don't
Yeah.
restrict any food types because that means
Yeah.
that you're
That
going to
means
have
you're
some
bad.
kind
Yeah.
of
Yeah.
it doesn't
Yeah.
make any sense to not
Well,
eat foods that
unless,
that
unless,
make no
unless you go
sense.
vegan, that's fine.
Oh
Yeah.
yeah,
Yeah.
that's really healthy.
No, that's fine. That's super healthy. Yeah.
Yeah.
But yeah, no, I have a patient, and she's a psychologist, and she works in food addiction and things like that, and eating disorders, right? And so and that's what the teaching is that no food is bad food. And so when I was talking to her about, the carnivore diet, because for her health issues, specifically, would be very benefited by doing that. And talking about that, it's really hard for her because her whole, she's like, I'm teaching these people that, no food is bad food. You have to eat everything and all that sort of stuff. And so I feel like a hypocrite if I didn't follow my own advice. And so yeah, it's very hardwired into the teaching there that everything has to be good. But of course, not all food is good food. Not all things that are called food are even food
Yeah.
in the first place. I mean, we're talking about like random chemicals and plastics and things like that. How is that food? Just because you put it in your mouth and chew it does not make it food. You can get nutrients and minerals and vitamins that are actually good for you from eating dirt. Does that mean dirt is good for you? Does that mean dirt is food for you? I mean, dirt might be good for you. People have pica, you know, women that don't eat enough meat and they have iron deficiency and they get pica. They actually do eat dirt, and they, because they bloody well need some damn iron because they're eating a deficient diet. So it can be conditionally beneficial in that. But does that mean that's food? Does that mean that dirt is food for humans? Of course not, right? And so, it's important to change that and have people aware that not all food is made equal.
Yeah, absolutely. So Jen Allen will be great, giving a great talk on that, and yeah,
Mhm.
it's going to be a really great conference once again. It's going to be our 9th year, so we're coming up to our 10th anniversary next year, but this year is our last in single digits. So if you
Nice.
would, if anyone would like to come and hear conversations like this, but many more of them, and many more experts coming to the table, and then do come along at the end of May and 31st of May and 1st of June in London, the Public Health Collaboration Conference. And if you can't make it in person, then please do live stream in. The link will be in this chat, and you can come along and watch the live stream over a period of weeks, as I mentioned before. So you'll get to hear from all the speakers that we talked about tonight, and Dr. Anthony Chaffee as well, and be the first to enjoy those talks. Otherwise, they won't be on YouTube for a while. So hopefully people will be able to come along and support us. And we are really looking forward to hosting you again in May, Anthony, and hopefully you'll have a nice trip over this side of the pond. And we're hoping to reserve you some nice UK spring weather.
Yeah. Oh, yeah. Thankfully, yeah. Well, it was nice last year. It was actually quite nice. That was probably like the
Mm.
four nicest days of weather I've ever seen in England. So that was good. Yeah, which
It's
is
always like that. It's always
not
like this
saying
here.
much, but
I think
yeah.
so. Anyway,
Well,
so
that's
thank you
yeah.
for your time this evening, and have a great trip over. And we'll be seeing you and anyone in the chat, anyone watching in May that comes along. So thank you for coming along and supporting us. So thanks everyone. Have a
Yeah.
great evening.
Thank you all. Yeah. Thank you very much. Thank you, everyone. And for everyone who's going, I'll see you there.
Yep. See you in a few weeks.
See ya.